All right, thank you everybody for coming to our program this afternoon. The topic is gynecological cancers. My name is Jennifer Miller. I'm an adult services librarian at the Scotch Plains Public Library. The program today is brought to you by Regional Cancer Care Associates, Central Jersey Division, Princeton Radiation Oncology, and the Scotch Plains Public Library. I'm very pleased to introduce our speaker today, Dr. Seeta Trivedi. She is a medical oncologist with Regional Cancer Care Associates, Central Jersey Division. So thank you for being with us today, Doctor.
You're very welcome, Jennifer. Thank you for having me. And thank you for attending this Lunch and Learn. September, as we know, is Gynecological Cancer Awareness Month. And we're here today for a short discussion on screening and detection of gynecological cancers. This affects all of us. We are all women. Some of us are more risk than the others, and this talk is intended to educate and to help us know about, what are our risk factors, what are things that we should look out for, what are symptoms to talk to your doctor about sooner rather than later, and some advances in treatment that science has made in this field of GYN malignancies. So to start off with, what is a gynecological cancer? So by definition, it's a cancer that starts in a woman's reproductive organs, okay? And that includes the cervix, cervical cancer, the ovaries, or uterus, okay? And the external gynecological parts, the vagina and the vulva, okay? Quite a bit of women, quite a few women are diagnosed with gynecological cancers every year. And unfortunately, the statistics are not small numbers. 94,000 women were diagnosed each year. The most common of these are, uterine malignancies, and the least common is vaginal cancer. Unfortunately, the most serious of these is ovarian cancer. Okay, and again, I think with the knowledge and information that we have today, and the ability to connect to our friends and family a lot more easier with phone and social media and etc., we hear a lot about cancer and cancer-related treatments. And ovarian cancer, unfortunately, is one of the 5 most dangerous cancers in women in 2019, along with, of course, breast cancer, which is, again, another female cancer, but it is in its own category by itself rather than a gynecological malignancy. So what we are going to talk about today is ovarian cancer, uterine cancer, cervical cancer, and a little bit about vulvar-vaginal cancers as well. And again, the focus of the discussion is on detection, screening, and treatment advances. Feel free to type in your questions or ask anything. You could be as technical as you wanted to in your questions, and I will certainly try my best to help you answer them to the best that I can. So this is a small diagram of the female reproductive system. As you can see, the lower part, the lowermost part of the reproductive tract includes the vagina. The lower part of the uterus is the cervix. The muscular body is the uterus, within which, obviously, a fetus or an embryo develops into a child. The ovaries are supported by ligaments. Ligaments are strong but thinner fibromuscular strands that keep organs in place. And these red straw-like organs are the fallopian tubes, which help to carry an egg into the uterus at the time of fertilization. Okay, so cancers can develop, unfortunately, in any of these organs. Ovarian cancers are often uh, treated similar to, sorry, let me rephrase, fallopian tube cancers are often treated similar to ovarian cancers due to the proximity and the sharing of a similar type of cell lining and cell tissue. And so we are going to discuss them as one entity. Uterine malignancies or cancers of the uterus, or cancers of what we call the endometrium, which is the inner lining of the uterus, are classified as uterine cancers, and we are going to discuss those. And then we are going to discuss cancers of the cervix or cervical cancers. So all women are at risk during their lifetime, all of us. And we all have heard prevention is better than cure. So the question is, what can we do to do that? What can we do to reduce our risk? Can we do to educate ourselves better? Okay. So there is no one particular age at which, one cancer occurs and the other cancer can't. Okay. As we go through our lifetime and as we continue to age, just like any other cancer, our risk of developing gynecological cancers also increases. There is also some variation in the type of cancers that we get by our race and our ethnicity. Um, and cervical cancer is usually diagnosed in general at a younger age. We are going to look at the factors for why that happens. Uterine cancer, ovarian cancer, vaginal and vulvar cancer are usually diagnosed in the older, which is over 50 and above age group. And for vaginal and vulvar cancers, it's usually even 10 to 15 years past that. The median age of diagnosis was around 67 years. Okay. So pretty much, all of these cancers can happen at some point in our lifetimes once we start going through, a slightly older adult phase between our ages of 30, 35, we can start having these cancers start to pop up in our life. And so younger women need to be particular and cognizant of certain things, and older women need to be particular and cognizant of some other things. Ovarian cancer, I'm just trying to see, all right, whether my slide is not loading properly. Okay. So who needs to be a little bit more careful about their ovarian cancer risk? And in general, there are a few risk factors that we are going to talk about that make us more prone or more likely to be at risk for ovarian cancer. Ovarian cancer, like we talked about, is the number one gynecological cancer causing the most deaths. Unfortunately, ovarian cancers are not always very self-evident or obvious up front. And so the more we know about them, the easier it is for us to know something might be wrong. The risk factors are listed them out as you start to get older, okay, postmenopausal, okay, age greater than 55. A strong family history of breast cancer or a family history of ovarian cancer. Recently, a few years ago, Angelina Jolie and her focus of her ovarian cancer battles was in the media, was in the limelight, which did tend to increase the spotlight on awareness. And so a first degree family member or first relationship, like your mom or your sister, these are called first degree relations, or more than one first degree relative having breast cancer or ovarian cancer should automatically make you aware of your risk and make sure that you are seeing a gynecologist on a regular basis and your doctor is aware of what your cancer risks are. okay? And that goes into point number 3 about women with known BRCA mutations, okay? BRCA, or what we call BRCA1 or BRCA2 mutations, or genetic mutations that can increase our risk of breast cancer, ovarian cancer, and the presence of these mutations in the family should automatically lead to some questions to your doctors about testing and assessing yourself for your own risk. Women who have personally had breast cancer should also be cognizant about their increased ovarian cancer risk. Obesity. So obesity, unfortunately, in the US is on the rise. Obesity is linked with an increased incidence of breast cancer, ovarian cancer, colon cancer, pancreatic cancer. Okay, so it should be something that all men and women think about, more so towards trying to use that as a trigger to move towards a slightly healthier way of life. Using hormonal therapy in your menopausal years, or using external hormones like estrogen alone or in combination with progesterone. Cigarette smoking. Again, smoking is associated with many different types of cancers due to the harmful, or what we call carcinogenic, effects of cigarette smoke. And smoking, unfortunately, can give rise to a more aggressive form of ovarian cancer called a mucinous tumor. Endometriosis, which is a benign or non-cancerous condition of the endometrium, can increase your risk. And then not having had children or having a late first pregnancy leads to a longer uninterrupted estrogen exposure on the ovaries that can also increase your risk. So what kind of symptoms do ovarian cancer cause? How can I say, okay, I have 1, 2, and 3, I probably have ovarian cancer? So there's nothing very specific like that. And that is a huge barrier for the reason why ovarian cancers are often diagnosed in later stages. The most important thing is persistence, okay? The symptoms are very non-specific, but most women see them as a clear and persistent change from how they used to feel before, okay? These symptoms do not tend to improve over time or may abate and then recur again with an increasing intensity or more severity, okay? And these symptoms include bloating, abdominal pain, lower abdominal pain, which is pelvic pain, trouble with eating, aversion to food, feeling full easily, eating followed possibly by nausea or vomiting, feeling like you have to go to the bathroom all the time, urgency, inability to hold your bladder so well. Okay, so all of these symptoms are not very specific and can happen in a wide variety of different medical conditions, but regular treatment or seeing your doctor's prescribing treatment independently for these things, the symptoms going away but then coming back and continuing to come back and continuing to get worse, should prompt the thought process that maybe this is something else, okay? As the cancer starts to progress, sometimes it is also associated with your belly filling up with fluid, which is what we call ascites, and that again can be a symptom of ovarian cancer and should prompt you to see your doctor urgently. This is sort of reflection of what I just went over, that symptoms are unfortunately not very specific. And so as you see here in the chart, the majority of the patients are diagnosed at a somewhat later stage, okay? Just to explain what staging of cancers are, most cancers are staged 1 through 4. 1 being an earlier stage of the cancer, and 4 being an advanced stage of the cancer when the cancer has become incurable. Stage 3, which is after 1 and 2 and just before 4, usually tends to be slightly more advanced, but still treatable. And in ovarian cancer, stage 3 is broken down again into 3 different levels, 3A, B, and C. And a majority of cancers, 58% of all ovarian tumors, are diagnosed in these stages. 17% of the patients are diagnosed at stage 4. Stage 4 is incurable ovarian cancer. And at the end of 5 years, out of 100, unfortunately, only 11 women are alive. And so it is important, again, to be persistent, to know your symptoms, and to talk to your doctor if you think something is wrong. How can your doctor find out that something is wrong? So the person to call is your gynecologist. There's nothing wrong if you want to call your primary care doctor to discuss the symptoms either, but usually you will probably get sent to a gynecologist who will do an internal exam. An internal exam is not a 100% sure way of diagnosing ovarian cancer, because like we saw in the pictures previously, an internal exam will allow your gynecologist to feel and look at your cervix. Probably a bimanual exam will allow your doctor to palpate or feel your uterus. But ovaries are usually hard to feel because they have a lot of fat and tissue surrounding them. Unless your cancer is at a very advanced stage, a physical exam or an abdominal or pelvic exam may miss a diagnosis of ovarian cancer, which is why doctors will then go to the next step, which is doing an ultrasound. An ultrasound is a test that uses sound waves. Commonly, when you're pregnant or if you're going through a pregnancy, again, your obstetrician will use an ultrasound, for example, to look at the baby. So it has no radiation, it uses sound waves only, and it is oftentimes a good way to look at the female reproductive parts. This again might allow us to see if there is a tumor or a mass on the ovarian tissue, but still, that does not always tell us whether it is cancerous or whether it is non-cancerous or benign. For this, oftentimes, a CAT scan or a CT scan is more specific. Some blood tests are more specific. And if need be, a sample of fluid or a sample of tissue called a biopsy may need to be obtained. A lot of us are doing our mammograms every year, and we do them to screen for cancers, to look for them before they may have happened or before they may be evident. Again, unfortunately, there is no good screening test. There are tests that can help us in diagnosis, but there are no tests that can be used in the general population with a common benchmark of finding a cancer. And that is because a lot of times an ultrasound, like I said, can find a benign tumor, it can find a cancerous tumor, or it's possible that visualization might not be too good. And so even if you go through the test, sometimes there is a risk of missing a diagnosis. And so there are no recommended screening tests that have been studied to consistently give us good results and allow us to say with 100% certainty that if you do this test, we will be able to find ovarian cancer. In patients who are at high risk though, and when I say high risk, patients that might fit the previous list of symptoms that list of either symptoms or risk factors that we went over, ultrasounds may be of use because those patients are already supposedly on high alert, and any abnormality should not go uninvestigated. Any symptoms do not go uninvestigated. And so blood tests and ultrasounds, transvaginal ultrasounds, or blood tests like monitoring a specific tumor protein in your blood that is called CA125 might point us in the right direction. CA125, or this blood test, is not, again, recommended for screening because there are a lot of benign or non-cancerous things that cause your CA125 to go up. And so if doctors started routinely doing these tests on everyone, they might wind up alarming a lot of people for no reason, and going through a lot of tests that you may not need, okay? But if you are at high risk, it makes sense to be on high alert and to be somewhat more upfront about what can or cannot be happening. Using these two techniques did not lower the incidence of death and dying. It did not save more lives. And so we do not recommend them as screening. One thing that I commonly hear in my clinic is women telling me, but I did all the right things. I did the blood tests. My doctor just ordered a bunch of blood tests for me and everything was normal. Cancers don't always show up in routine blood tests. Routine blood tests often include things like checking your blood counts, your liver function, your kidney function, checking your cholesterols, maybe checking some vitamin levels, maybe checking some thyroid functions, checking to see if you have diabetes. But they do not include blood tests to screen you for cancer because these tests are not always accurate. Unless your cancer is specifically causing some sort of damage to any of your organs, like your blood-forming organs, or your liver, or your bones, the blood tests will not reflect a presence of cancer. And so again, we come back to the point that if you are symptomatic with the things that we talked about, if these symptoms are not getting better in spite of some basic treatment or intervention, if you are at higher risk, as we talked about it, make sure you think about or talk to your doctor about the possibility of whether you may have ovarian cancer or not. So let's talk a little bit about familial cancers, because again, that is a very common topic of discussion in my clinic about how that changes our risks. And like we talked about, just because someone in your family might have a cancer does not necessarily mean that you're going to be at high risk, okay? Geneticists or genetic counselors look at a wealth of information and different pointers to see whether these things add up to actually your risk being higher. And that is what we use along with specific guidelines to be able to tell if you're at risk for a cancer just because somebody else in your family is at risk of cancer too. And a very important one is age at the time of diagnosis. Cancers that are caused because of hereditary or genetic problems or genetic mutations that get handed down from generation to generation tend to happen at an earlier age. These are not cancers that might happen in, for example, your grandmother who had breast cancer at the age of 75. If that is the isolated event, it's likely that grandma had cancer because of her age causing damage to the breast tissue and eventually development of a cancer. What you can do about that for any family history, obviously, is see what you can do to get screened. And screening starts at age 40 with your mammograms. Screening also starts at age 45 for colonoscopy, for colon cancers, for rectal cancers. And in men, screening starts at age 40 for prostate cancer. So if you fall into an average risk, women should consider talking, of course, to your doctor and going through routine and regular health screenings if you do not have any additional risk factors. So those people are at normal risk. What about in between risk or moderate risk? Say you have two people in your family who have breast cancer. Say you may not know what age they have breast cancer. Maybe they had cancer around the age of 50, which is usually used as a cutoff point in order to try to determine, whether it was a cancer at a younger age or an older age. Not that, 50 is old, but just in terms of using it as a benchmark for when you may be considered to be older. Say your mom had breast cancer at the age of 68, and her sister had breast cancer as well at 62. So now we have two cancers, not exactly happening at an older age, not really at a younger age either, but two specific events. And, you're not exactly sure whether this increases your risk of breast and ovarian cancer. So as of this day and age, still, if you have two cancers past the age of 60, genetic counseling may not be indicated, and screening for cancerous genes may not be indicated unless you are of Ashkenazi Jewish or Eastern European Jewish ancestry, in which a lot of these cancers can cluster, can happen in varied age groups. And so again, you should be cognizant about your risk, and you should make sure that you are getting your screening tests. But what is high risk? So high risk is cancers happening in one or more family members that are first-degree relatives younger than the age of 50 or younger than 45. Or if you have a specific kind of breast cancer that we call triple negative breast cancer at an age younger than 60. Or you've had a male member of your family had breast cancer, or your mom or a first-degree relative like a sister have ovarian cancer, or there are clusters of 3 or more cancers. Okay. In these kind of patients, when we are suspecting that there is a stronger cancerous risk, we do recommend that you see a genetic counselor. We do recommend screening for mutations, BRCA1 and BRCA2, or BRCA1 and BRCA2, which used to be the only two known hereditary cancer-causing genes for breast and ovarian cancers, are not the only ones we know about. We now have several other mutations. There's a total of 9 that we check for routinely when we are looking and screening at these patients to see if they have one of these mutations that can cause cancer. So again, you can talk to your gynecologist, you can talk to your primary care doctor, or if your parent or sibling has an oncologist, you can certainly talk to them about it, okay? If one of your family members has a known mutation, a first-degree family member, then you should get tested for that mutation alone. You don't have to be tested for all the mutations, because the likelihood of getting cancer will be from that same mutation that is being passed down in your family. And if you are negative, then you can rest easy that your children then are not at risk because you don't have the gene. These genes usually do not skip generations or are what we call autosomal dominant. There are a lesser number of less common mutations that could be recessive or skipping generations. And again, your counselor will tell you if it's one of those genes. I think I covered a lot of this in the previous discussions, but just to sort of summarize, if you are testing positive for a BRCA1 or 2 mutation, then your doctor will recommend screening for ovarian cancer, which is an ultrasound every 6 months, blood test every 6 months, and most importantly, letting you know that you should get screened for not only ovarian cancer, fallopian tube cancer, uterine cancer, but also for breast, pancreatic, and for your male members, prostate cancer and colon cancer as well. Briefly about staging. Like we talked about, staging goes from 1 to 4, 1 being earlier stage, 4 being the more advanced stage of breast cancer. 1 usually means the cancer is limited to the organ or the ovary alone. Stage 2 means it's spreading a little bit in the surrounding outside the organ. Stage 3 usually means it's involving the lymph nodes. And stage 4 means that the cancer has traveled outside the organ it originated in to some of your more important organs like the bones, the lungs, or the liver. Staging for cancer, treatment for cancer is often recommended by stage, and it is important to get an accurate stage prior to starting treatment to make sure that you are getting the best treatment according to the best and latest recommendations. Cancer treatment is a multidisciplinary form of treatment. It's not just one doctor. It almost always involves a group of 3 doctors, your surgeon or your surgical oncologist, your radiation doctor or a radiation oncologist, and a doctor like myself, who's a medical oncologist who deals with giving patients medicines to treat cancer, what we commonly call chemotherapy. But cancer treatment has moved beyond just what we call chemotherapy or medicines to kill cancers. We are now able to identify certain molecules, certain mutations, certain pathways that the cancer cells seem to grow by, and target them to slow them down. These treatments are called targeted treatments or personalized medicine, precision medicine. And that is the science of tomorrow. And that is where oncologists and doctors around the world are hoping for advances to make patients live longer and to make treatments more effective. Lots of different surgical options for ovarian cancer. In general, they include either starting with surgery upfront if the doctor feels that everything can be removed very easily with very little cancer being left behind, which is important because any cancer being left behind is just going to grow back. Other option is to try to shrink it first by giving you chemotherapy first, checking your scans a few months later, seeing if your cancers have shrunk. And if they have, then going in and taking the cancer out. Or in certain patients, doing all the chemotherapy first, waiting for a bit, making sure the cancer is not growing, and then doing a slightly more complete surgery to try to salvage or to try to make sure that the cancer is given its best chance not to grow back. Okay. Patients who have stage 3 cancer may also be given chemotherapy inside the abdominal cavity, which we call HIPEC. And for this, a special port or a special access is implanted when patients go for surgery, and then chemotherapy is administered through that port as well. And these surgical options have been pretty standard. Techniques have improved. Surgical hospitalization times have been reduced. Techniques with robotic surgery or laparoscopic surgery are getting more accurate, more precise, less blood loss, shorter hospitalization stay after surgery. So you want to certainly consider all your surgical options when you're talking to your gynecologist. This slide has been placed from the NCCN website. NCCN stands for National Comprehensive Cancer Network. It is a uniform group of guidelines that most medical oncologists throughout the US and oftentimes around the world follow to guide us for treatment, to help us decide what treatment is better or what treatment has been proven to work more effectively, gives us the opportunity to review data or studies that allow us to know what tends to be better for specific kinds of patients. The backbone for treating ovarian cancer or fallopian tube cancer, or what we call primary peritoneal cancer, which is the covering, the skin covering over the ovaries and the tubes, includes two main drugs, a platinum drug, carboplatin, cisplatin, in combination with a taxane, paclitaxel or Taxol, docetaxel or Taxotere. And these two drugs are generally utilized first, up front. They're generally utilized as the best agents that we know of. If those do not work, there are many other targeted treatments, many other additional chemotherapy drugs, and many other combination drugs that we could use in order to try to see if we can bring the cancer under control. A lot of times, women hesitate to reach their diagnosis, hesitate to reach out to their doctors about symptoms, even though they know that something could be wrong. And the primary reason is because they're afraid of getting chemotherapy. And as a community oncologist, I'm here to assure you that medicine has progressed, supportive care has improved, our knowledge of how to treat chemotherapy-related side effects has improved. The places where you can go to for help, the access to nurses, to doctors is better. And the fear of that alone should not stop you from reaching out to your doctor and trying to figure out if something is wrong. Some of the more modern things that we have available, like I talked about, precision medicine includes patients who have BRCA positive tumors. For them, special oral forms of pills that we call PARP, P-A-R-P inhibitors or PARP blockers do seem to work very well in these cancer patients. Immune therapy, which is something a lot of you may have heard about, immune therapy or immunotherapy or using your body's own immune system to fight cancer. It seems like an awesome and amazing concept, but is still trying to get to the side of perfection. Can be used only in certain specific types of ovarian cancers, unfortunately not all of them. And your doctor will test your cancer to see if that is something that they can use. And certain other targets that may have utility in other cancers and certain other specific or personalized mutations that you might have that we have treatments against could be used as well. I'm just going to skip this slide, which goes over mechanism of action of PARP inhibitors. We can come back to it later. Let's talk about, because to talk about cervical cancers, I want to talk a little bit about uterine cancers. So let's talk a little bit more about cervical cancers. But in general, what I want to summarize for ovarian cancers is that given that they are very common, given that they are hard to detect, and given that there is oftentimes a small window of opportunity to cure them, again, I just want to let people know that If this is something that you are considering, please talk to your doctor about them. Please discuss your symptoms, and please seek care with an oncologist or a gynecological oncologist for the best possible treatment. Cervical cancer is common in younger women, and it is most often associated with another type of virus that we call the human papilloma virus, or HPV. We've known about HPV for a long time, and we know about the different kinds of cancers that it can cause. Unfortunately, cervical cancer is not the only one. HPV can cause anal cancers, it can cause mouth cancers, it can cause neck cancers. And so again, it's something that can be screened for, can be looked for, and can be diagnosed and detected before it has a chance to cause cancer. Smoking, patients who have HIV or AIDS and whose body's immune system is not too strong, having sexual experiences earlier in life, in early teenage years, having several partners, having had several children, using birth control pills for a longer time, which can change the composition of the mucus around the cervix and increase the risk of cancerous formation, are all risk factors for cervical cancer. There's around 150 different types of HPVs. There are some that are scarier. HPV type 16, type 18 are the two most common ones that can increase your risk. Like I said, cancer of the penis, vulvar cancers, vaginal cancers, anal cancers, mouth, oropharynx, your tongue, your tonsils, and throat cancer. And most people don't know if they have or have not been infected with HPV. So again, the only way is to be screened and to be tested. 79 million Americans are infected with HPV currently, and 14 million new patients get infected every year because it's a ubiquitous virus. It's a virus that's all over, all around us. And that's the reason why it is important to know about it. So what HPV can do is, again, it infects the cells of the cervix. It goes into the nucleus, which is the center motherboard of the cell, and it changes how the DNA or the genetic material forms and causes malformations or mutations in the genetic material. And those misformed or abnormal cells then start replicating, and they wind up forming a cohort or a group of cells that are cancerous. If you get infected by an HPV strain that is low risk, then you wind up with non-cancerous things like warts, which are again caused by HPV. And as you can see over here, the structure of how the cervical cells look under the microscope after you've had an HPV infection changes until finally the cells turn cancerous and start to grow and invade surrounding structures. I'm going to go, I'm not sure what is going on here, but let's go to detection and screening. So what do you want to do to screen for cervical cancer? Well, you want to make sure that you get your pap smear done. Okay, all of us, I hope, have heard of what a pap smear is. You have to go to your gynecologist to get a pap smear. And it involves taking a small sample of cells from the cervix, and then the doctor sending it to a pathologist, and the pathologist looking at it under the microscope to see if any abnormalities can be detected. You don't want to do it when you have your period. You don't want to use vaginal creams or moisturizers or douche a few days before the test, and avoid sexual intercourse as well to prevent injury to the cervix a few days before your test as well. And screening for cervical cancer with the pap smear also involves testing you for HPV. And so if you have a specific high-risk HPV virus, like we talked about, your doctor will tell you of what precautions or interventions you might need to have. And your pap smear test will list different categories of what they're seeing. And if you have a normal test, it will say it is negative for an intraepithelial. Epithelial or epithelium is the lining of your cervix. Intra means inside. So it's negative or does not, your pap smear does not have any changes in your cervical lining. There's no cancer. Malignancy is another word for cancer. There are no benign or non-cancerous changes to that lining. And there are no other types of cancers or infections or anything else in your cervical area if you have a clean report. When is the right time to start having your pap smear? So all pap smears and cervical cancer screenings should start at least at age 25, okay? Women that are younger or may have started sexual intercourse at a younger age or have multiple partners should start getting tested earlier and should start getting either yearly testing or more frequent testing if they are noted to have cervical abnormalities. As you get a little older, you should have a test done every year to 3 years or every 5 years, depending upon what your doctor says. And once you get past a certain age, you may not need to have your pap smear done every year. And past the age of 65, if you've never had an abnormal pap, you don't need to keep on getting them because the chances of those changes that take place over a period of time start decreasing significantly. If you've had a hysterectomy, if you've had your cervix removed, you don't need to have a pap smear, obviously. And if you have been vaccinated with the HPV vaccine, it's still a good idea to get screened. I think these slides are just not playing out in the right way that I would want them to, so I'm going to skip this slide. We'll go to the topic of HPV vaccinations. There is a vaccine that is out there for prevention of HPV-related cancers. It's called Gardasil. Gardasil 9 is the one that is currently approved. And it does help to prevent cervical cancer by preventing your body from being affected with the cancer-causing HPV viruses. HPV 16, 18, and 5 other types of HPVs that can cause cancers. It reduces the incidence of these. It reduces the possibility that you get infected. And so over a period of time, the changes that are going to happen in your cervix are less likely to happen, and hence less likely that you will get cervical cancer. And again, prevention is better than cure. Most of the cancer societies and organizations, including this slide that we have from ASCO, are the American Society of Clinical Oncology, as well as the American Society of Gynecological Oncology, CDC, and other organizations routinely recommend getting the HPV vaccine, getting tested, again, getting your pap smear. HPV, like I said, is preventable. All boys and girls, once they get past the ages of 11 or 12, should get vaccinated. And certain patients who are in a higher risk group should get vaccinated as well. If you're children, or if you know people who are in the age group of 9 to 14, then you're going to get a shot, and then you're going to get another shot 6 to 12 months later. If you're older, you might need to get a series of 3 injections, but most of the times, the side effects from the injection, from the vaccine, are small compared to the extremely high prevention and protection benefit that the vaccines offer. Let's now move on to uterine cancers. Uterine cancers are cancers of the uterus, very common in the US. They usually happen in the postmenopausal years. And that's the good part about them is that they are very easily detected, because in postmenopausal women, you start spotting. Most of the times you think something is wrong and you see your doctor. Uncommon under the age of 45. And again, going through risk factors, we see some of them are things that we have reviewed or gone through. Estrogen, in terms of postmenopausal estrogen replacement therapy, women who are obese, women who have not had children, women who went through menstruation for many years uninterrupted, having your periods, starting your periods early, getting menopause late, and not having any pregnancies in between leads to, again, years and years and years of constant estrogen stimulation on the endometrium, which can increase your risk of cancer. History of breast and ovarian cancer, history of polycystic ovarian disease, history of pelvic radiation for some other reason, endometrial hyperplasia, using certain drugs like tamoxifen, which is used commonly for breast cancer patients, diabetic patients, and patients who might have something called Lynch syndrome, which is a hereditary colon cancer syndrome, are also at higher risk for endometrial cancer. Most common symptom is postmenopausal bleeding. Usually there's not really any pain or discomfort or anything else, but because the endometrium or the inner lining of the uterus starts to get thickened, it starts to shed, just like you would if you were getting your period. And that causes something as simple as spotting, discharge, or in certain women, heavy bleeding, all of which should prompt you to see your doctor. Cancer that has spread beyond the uterus may be causing symptoms like pain, frequent urinary tract infections, gastrointestinal symptoms like nausea, vomiting, or diarrhea, and again, abdominal swelling, bloating, or fluid collections. Cancer staging, just like other cancers that we talked about, stage 1 or early stage, limited to the uterus, stage 2, slightly advanced, stage 3, involving the lymph nodes, and stage 4 is cancer that has traveled outside the uterus, got to other organs, and causing damage elsewhere. A visit to your gynecologist, a bimanual exam, and oftentimes an abdominal exam can detect endometrial cancer. If they cannot, your doctor will recommend further imaging, such as an ultrasound or a CAT scan. Most uterine cancers are low grade or not very aggressive, and most of them tend to get diagnosed in either stage 1 or stage 2, because there is a very specific and obvious symptom that is associated with it that most women tend to be concerned about and see their doctors about. There are some more aggressive type of uterine cancers also, which are undifferentiated cancers, or cancers that do not follow a regular pattern of growth. These cancers are not estrogen sensitive. They're not associated with the regular symptoms, and they're not associated with regular growth patterns, and are higher grade, such as leiomyosarcomas, or mucinous carcinomas, or carcinosarcomas. And all of these are, unfortunately, very aggressive kind of uterine cancers. All in all, symptoms still remain the same. And so if you see any spotting or see any bleeding, and you're a postmenopausal woman, you should still get it checked out. We talked about diagnosis, which is going to be with ultrasound, taking a biopsy, which is a part of the endometrium. A common procedure is what doctors refer to as a D&C, a dilatation and curettage, but it's the curettage or the scraping of the endometrial cells by your doctor, by your gynecologist, and allowing the pathologist to look at those cells under the microscope that helps you make a diagnosis. Treatment usually is a hysterectomy, or removing the uterus in its entirety, and that is usually curative. Curative meaning once the uterus is out, most of the times the problem is gone. Depending upon what stage it is, however, as you get to stage 2 and 3, you may also need chemotherapy to make sure that none of the cancer cells that have escaped the uterus are going to go and settle down somewhere else. And so systemic chemotherapy may be indicated depending upon other factors as well, and you should talk to your doctor about that. If you have been diagnosed with an advanced stage of cancer, then certain other tests on the tissue itself can again help to identify certain more specific treatments that could be used, such as testing for estrogen receptors, progesterone receptors, HER2 receptors or human epidermal growth factor receptors, and checking to see if you're a candidate for immune therapy. We did not get too much time to talk about vulvar or vaginal cancers, but most of the times, symptoms of these cancers include bleeding, itching, pain during intercourse, change or a lump that you might feel when you're washing or cleaning, constant discharge, foul-smelling discharges, changes with regards to pain. And again, if you have any of these symptoms, you should see your doctor. Treatment is often surgical. And again, the earlier it is picked up, the higher the chances are that you will be able to be cured. Ovarian cancer, uterine cancer, vulvar and vaginal cancers, and cervical cancers are all cancers that we as women are at risk of developing in our lifetime. And so the more we educate ourselves about them, the more likely it is that they can be picked up in an earlier stage, treated, cured, and helps to save lives. If you have any questions or concerns, you can feel free to email us or reach out to us, but I'm open to taking any questions that any of you may have at this time.
Doctor, I just want to thank you so much. That was a tremendous amount of information, but it was incredibly clearly presented. And I think that that's really empowering to all of us. So I really want to thank you.
You're very welcome, Jennifer. Like I said, thank you so much for this opportunity. I think, we just need to make sure that we are educating, and library is the best place for that. So I'm again very thankful to the Scotch Plains Public Library for having us at this lunch.
Oh, it's a pleasure. And also, I would just like to extend our thanks to everyone at Regional Cancer Care Associates Central Jersey Division and Princeton Radiation Oncology, who worked to make this possible as well. So we'll end the recording here.